A child has 6 days of persistent fever, red eyes, and a rash. If you miss this diagnosis, coronary artery aneurysms form quietly and rupture weeks later. This is Kawasaki disease, an acute febrile medium vessel vasculitis of childhood and the leading cause of acquired heart disease in children. The danger in Kawasaki disease is not the fever or rash. The danger is coronary artery inflammation that progresses silently if untreated. Kawasaki disease typically affects children under 5 years, especially those of Asian or Pacific Islander descent. The exact cause is unknown, but current evidence suggests an abnormal immune response triggered by infection in genetically susceptible children. Clinically, diagnosis is pattern recognition. It starts with fever lasting at least 5 days. This is mandatory. Then look for 4 out of 5 classic features remembered as crash. C is for conjunctivitis, bilateral, non-purulent red eyes without discharge. R is for rash, polymorphous, non-vesicular type, sometimes urticarial or erythema multiform-like. A is for adenopathy, typically unilateral cervical lymphadenopathy, firm and non-tender. S is for strawberry tongue, red, cracked lips with inflamed oral mucosa. H is for hand and foot changes, erythema, swelling, followed later by desquamation of the palms and soles. Arthralgia or arthritis may also be present. Laboratory findings support the diagnosis but do not make it. You'll see marked inflammation, elevated CRP and ESR, leukocytosis, and later thrombocytosis, typically peaking in weeks 2 to 3. Liver transaminases may also be elevated. The most important investigation is echocardiography. Every child diagnosed with Kawasaki disease requires an echo at diagnosis, and again at 2 weeks and 6 to 8 weeks, to assess for coronary artery aneurysms. Diagnosis is clinical, fever for at least 5 days plus 4 of 5 crash features. Incomplete Kawasaki disease still exists, and missing it is dangerous. Differentials matter, but patterns separate them. Scarlet fever has a sandpaper rash and streptococcal pharyngitis. Staphylococcal scalded skin syndrome has a positive Nikolsky sign. Takayasu arteritis affects large vessels and causes weak pulses, not mucocutaneous findings. Treatment must be immediate. The cornerstone is intravenous immunoglobulin given to all patients, ideally within the first 10 days. IVIG dramatically reduces the risk of coronary artery aneurysm formation. Along with IVIG, give high-dose aspirin initially for anti-inflammatory effect, then transition to low-dose aspirin for antiplatelet effect. Aspirin is continued if coronary abnormalities are present and stopped only after imaging confirms normal coronary arteries. Children at high risk of thrombosis may require anticoagulation. Because aspirin is used, influenza and varicella vaccination is essential to reduce the risk of Ray's syndrome. Without treatment, up to 25% of patients develop coronary artery aneurysms, leading to thrombosis, myocardial infarction, or sudden death, sometimes years after the initial illness. With early recognition and treatment, Kawasaki disease is usually self-limited, and outcomes improve dramatically. The takeaway is simple but critical. Kawasaki disease is not a rash diagnosis. It is a cardiac emergency disguised as fever. Miss it, and the heart pays the price weeks later. This is the Why Medic. Subscribe for more high-yield topics.